So, Shiva sir, I'll do a disclaimer and also show how to take questions.
Yes.
Sure. In the beginning, then I'll hand it over to you.
Okay, fine.
I mean, how to take questions on website. Of course, the number is behind you also.
So they WhatsApp the questions, is it?
Yeah,
Yes,
you can see the number behind me.
Yeah, sure.
Okay. In the message also we have sent the same.
And they can also send it on website. So
on the chat also.
Okay. So let's start. Good.
Yeah, sure.
I'll start and then hand it over to Sir.
Yeah, absolutely.
Good morning, everybody, and welcome to this third edition of One Talk, One Speaker with Dr. John Mukhopadhya and Dr. Shiv Shankar. I'll take you through certain disclaimers in the beginning so that we are clear about it. We thank all our faculty for sharing their knowledge and expertise in this challenging time. We wish our audience a healthy and safe day ahead. These webinars are dependent on internet speed, so bear with us if there are any issues with the internet. I'll take you through how to ask questions on the website. Of course, there is a phone number just behind the background of Dr. Shiv Shankar, and you can send your questions there too. This is the Ortho TV website where you can see us. And just below the title, you have the question answer panel where you can type your questions also. So again, welcome to all. And I'll be handing it over to Dr. Shiv Shankar now. Over to you, sir.
Thank you very much, Ashok. It's a great pleasure to have Dr. John Mukhopadhya from Patna, who will be sharing his enormous experience on intra articular malunions, as well as he'll be giving some tips for avoiding complications. Dr. John has done his MBBS, then he has completed his FRCS from Edinburgh and MCH from Liverpool. He is heading the Department of Orthopedics and Traumatology at Paras HMRI Hospital in Patna, and also is the director of Mukhopadhya Orthopedic Clinic and Research Institute in Patna. Dr. John is the chairman of Orthopedic Research and Education Foundation in India. He is member of Regional Education Training Team, AOT Trauma, Asia Pacific Pediatric Fracture Expert Group, AO Trauma International, etc. He is on the editorial board of the Patient Safety in Surgery, that is a e-journal, and also Strategies in Trauma and Limb Reconstruction Surgeries from Springle Verlag. And he is also on the reviewer on the board of Indian Journal of Orthopedics. He has been the faculty at various national and international conferences and meetings, and he has been on the board of faculty for AO India trauma courses, regional faculty at various countries in the AO trauma, and also in the international, he was the international faculty at Davos as well as in UK. Dr. Mukhopadhya has also authored textbook chapters on clubfoot and distal humeral fractures, and he has various publications and index journals to his credit. Friends, Patna is one of the center where lot of complicated cases comes from nearby places and including nearby countries from Nepal and Bangladesh, and they have an extensive experience of dealing with complicated cases. So with this few words, I introduce you to Dr. John, to whom we are eager to listen. So meanwhile, I'll just say that you can see the mobile number of me or the WhatsApp number. You can ask your questions on that, as well as Dr. Ashok Sham said, on the panel in the Ortho TV. Thank you very much. John, it's all yours now.
Yeah, thank you, Shiva, for the kind introduction. And it really is a tremendous honor to be doing this webinar. and also a big responsibility, because I think giving such a long talk as a single speaker is really something which is daunting. So I'm going to talk about joint salvage in intra-articular malunions, which is a kind of area which I have a lot of interest in. Over the period of time, just moving forwards.
Just click on the slide, it will move.
Yeah, okay. So I think over this talk, I would expect people to really hopefully learn how to assess intra-articular malunions, decide on how to make a treatment plan, and if they're planning surgery, how to plan your surgery. But most importantly, I think I would like people to look at intra-articular malunions differently from what we were used to. So when we look at intra-articular malunions, they're actually a significant clinical problem. There are no easy answers. And if you don't do anything, many of them will end up with significant osteoarthritis and problems in the joints, especially in the weight-bearing joints, and often end up with either an arthrodesis or an arthroplasty. And we started looking at whether it's possible to salvage the joint and avoid these surgeries which end up in arthrodesis or arthroplasty for these patients. And my interest started many years ago. And one of the people who inspired me to some extent was a talk I heard from Professor Rene Marti in one of, it was the Indian Orthopedic Association meeting many years ago in Delhi, when he was scheduled to talk on proximal tibia malunions at 8 o'clock in the morning. And I went there, and there were hardly 7 or 8 people in the hall. But that talk was really something which was an eye-opener for me at that stage, and kind of then started me thinking of what we can do with some of these patients who come to us late. I think whenever you're dealing with any patient with a malunion, I think you need to start with a clinical assessment. You need to assess them in terms of the symptoms, the deformity, disability, if they have any joint instability, as well as you need to look at the range of motion. And then you need to assess them radiologically. And the problems may be extra-articular, intra-articular, or combined, or you can have areas of joint incongruity, and you really need to demarcate that. So when you're talking about the knee, for example, and I'm going to concentrate my talk mainly on the proximal tibia and then show examples from other parts of the body where we can hopefully salvage a joint in a difficult situation. So if you have a situation like this, where someone had a medial condyle fracture, and that's gone on to heal, but it's gone on to heal with the medial condyle tilted and in a bit of varus. And if you look at the overall alignment of the tibia, it's in varus. You then need to look at the CT scans to look in terms of where the deformity is, where the intra-articular malunion is, if there's any step off or things like that, which you can correct at that time. So here's an example. This is a gentleman in his early 30s who came to us about a year after this injury. And this is the same patient I showed in the X-ray there. But if you analyze it a little carefully, you can see that's where the original fracture line was. The alignment is in varus. But if you look at the joint, you have 2 different joint lines to the proximal tibial condyle. So if you just correct it extra-articular, you're going to still have an incongruent joint, although the overall alignment may be okay. So here you need to do an intra-articular osteotomy. You need to elevate a hemiplateau of the tibia, in this case, put in bone graft, and then fix it with a plate so that you get correction both of the intra-articular problem and the overall alignment of the limb. So this was the post-op picture. You can see the overall alignment of the limb has also improved, and a 1-year follow-up showing good function and a good maintenance of the correction that we had done originally. Sometimes you have to deal with an intra and extra-articular problem, and this gentleman had this intra-articular fracture which had sort of healed with the medial condyle tilted, but he also had an overall varus of his limb. So here you do an intra-articular osteotomy, again, similar to the previous one, elevate the hemiplateau, put in bone graft, but you also want to correct the overall alignment of the limb. So you also do an extra-articular sort of osteotomy and correct the varus overall alignment of the limb. And then you can get a correction both of the intra-articular problem and the extra-articular varus of the limb so that you get a good knee that can last you for a long time. Other problems involve parts of the joints. Okay, so it may not be the entire hemiplateau, which is depressed, but it could be a part of the plateau. This young lady came to me about 4 to 5 months after the initial injury, and her main problem was instability. So someone actually referred her to me as a ligamentous problem. She was going into valgus, and then you looked at the X-rays, obviously very carefully, and you can see there's a depression on the lateral side, but it's difficult to assess the depression just on the X-rays. And here's where the CT comes in useful. And you have to look at all the planes on the CT, the axial, the sagittal, and the coronal planes to look at the deformity. And if you look at it carefully, basically involves the posterolateral part of the condyle, but there's a rim of bone which is in the correct place. So again, this 3D shows this up clearly, how you can see there's a tilt. This rim is okay, but there's a tilt in this deformity here. So you have to decide how you get access to it and how you can correct it. And in this case, we felt we had to make a lateral cortical window. So we actually did an osteotomy of the lateral wall, the rim part, which was actually more or less in the correct level. And now you can, because this was about 3 or 4 months down the line, you can still see the old fracture line to some extent. It's healed there, but you can actually recreate the fracture line, elevate that part of the tibial condyle. That means front and back, more in the back than in the front. Adequate either bone substitute or bone graft. In this case, we used bone substitute. So you can see the C-arm images. We've got it elevated. We put a K-wire, which we pull out through the opposite side. Okay, so what we do is we put in the K-wire, I'll show you that later, and then put in the plate. So the K-wire actually gets pulled out from the opposite side. We put in the bone substitute, and then we fix it with the plate. So this is her 1 year post-op. You can see how she's maintaining correction. She has a fairly good function, very good function, and now the instability which she had earlier has gone. Now you can have problems involving the medial side as well. That was on the lateral side, and this posteromedial fracture fragment, which now people are much more aware of than earlier in the tibia, can also cause a problem. And here you can see this is a posteromedial depressed fragment. You can see the double shadow on the medial side. You can see the huge step off on the CT and the depression here. And you need to find out how you can get this back into position. And in this case, because it's a posteromedial fragment, you need to do your osteotomy through here and elevate it. So this is sometimes not so easy as it looks, because getting this fragment back up is not easy. That's the C-arm images showing the double shadow, the osteotomy from the back. You can see we've used the posterior posteromedial approach to the proximal tibia. You go and then you elevate this up. You put in a lag screw and then a buttress plate and bone graft to support the elevated portion. So here it is in the C-arm images. Now you can see there's only one shadow on the medial side. There's one lag screw across and a buttress plate. This is her at follow-up at about 4 months. And this is her at 18 months. Again, you can see how she's maintained the correction and has got a knee function, good knee function and alignment. You can have more complex problems. And this gentleman in his 40s had this kind of very severe deformity and had been fixed with these screws, which really weren't doing much in terms of either reducing or holding the depression. Again, if you look at the CT, you can see this huge depression here. There's the posteromedial fragment. This is the anterior part, which is almost, so the femur has subluxed with the posterior part, and you have to now get this back and the femur back into place. So here, one of the problems is approach, because on the medial side, getting to here is difficult because of the medial collateral ligament. And here we can sometimes make use of a medial epicondyle osteotomy. So you do an osteotomy of the medial epicondyle, turn down the entire fragment, and that gives you a visualization of the bone. And you can see where the anterior part is and where the posterior part is. This is a huge depression. You need to osteotomize it, get this up. You need to use a distractor in these old cases, get the articular surface as well aligned as possible, put in a lag screw and a buttress screw. And this is him at follow-up about 7 months down the line. He still has a little bit of varus, but if you looked at the original position of the knee and the situation of the knee, that was going to be a knee that's going to be destroyed fairly soon. At least this is now going to go on for a few years before he has any significant problem in the knee. Other complex non-unions where you have part of the lateral condyle subluxed out, you have a varus with a deformity here. And here you have to plan how you can get this part of bone back under the femur condyle and as well as the alignment corrected. So here your osteotomy will actually have to take off a bit of segment of bone in this area, because when these patients come late after 7 months or a year, you can't reduce this back again. So you need to take off bone, create a space for this fragment to go in. Okay, so your osteotomy has to deal with the overall varus alignment, but also deal with how to get back the lateral wall into the joint. So you do your osteotomy intra-articular, you actually then excise a segment of bone in that V shape that I mentioned. You also do an extra-articular osteotomy across it to correct the alignment. And then you can try and fix this fragment back under the femoral condyle and get a reasonably good alignment. Now, you're never going to get absolutely perfect looking x-rays in these very late cases, but you're able to salvage the joint, which can then function reasonably well for a long time to come. So we'll end up with a clinical case we treated some time ago. Now, here is a 55-year-old gentleman who presents 6 months after this injury. And you have to decide what you do. Are you going to leave it alone? Are you going to wait for things to get bad enough that he requires an arthroplasty? How are you going to intervene and do something now? And you can see, if just looking at the x-rays, you can see there's a depressed area here. There's splaying of the lateral condyle. And you also have a double shadow on the medial condyle. It tells you that there was a split depressed segment of the posteromedial condyle. So you need to plan your surgery. Of course, you need to do your CT. You can see the depression here on the lateral side. You can see the split depressed fragment on the posteromedial aspect. And those are the 3D CTs. And then you have to plan your surgery. So again, we started on the lateral side. There's a submeniscal arthrotomy. We created the lateral window with the area that was not depressed, so cutting it through that so that we could visualize the depressed area here. Okay, so you can see this area is depressed, and this was just the initial exposure to kind of assess things on the lateral condyle. Then we went across to the medial side, did a medial epicondylar osteotomy. That's the step on the medial side here. So you do your osteotomy through that area. Okay, so there's your osteotomy. You elevate the medial posteromedial fragments till so that you get the joint nicely aligned. You put in a lag screw from front to back and then a buttress plate on the back. Okay, then you need to obviously repair the medial meniscus as well as reconstruct, fix back this medial epicondyle fragment, which we usually do with a 6.5 cancellous screw with a spiked washer. And then we go back to the lateral side. We elevate the depressed fragment here. We put in bone graft into this area so that, but on top, after you do that, you still need to get this fragment back. So again, you need to excise a segment of the lateral wall, nibble it off. You can see how this part has been elevated nicely here. And then you can put this lateral wall back so that it is within the joint. Again, you put in your provisional K-wires and then do your definitive fixation on the lateral side as well. And so this is the reconstruction. You can see how now the joint is well reconstructed within the joint. This is the wound a few days later. This is him at about 5 months or 6 months post-op, and this is him 9 months post-op with good function, good alignment. And this is a 15-month follow-up with sort of a very good range of motion and excellent gait as well. You can also have problems where you have bony as well as ligamentous problems combined, okay? And this becomes a more difficult thing to deal with. This is a patient who presented to us at 3 months with varus instability of the knee. These were the x-rays at that time, but if we go back to the original x-rays, I think he had this femur fracture. I think initially the tibial fracture was missed. This was nailed, then they discovered the proximal tibial injury and then fixed it with these 2 screws. But if you look very carefully on the lateral side, there's a speck of bone there, which is actually an avulsion of the lateral ligament from its femoral attachment. Okay, so he had an unstable knee as well as a deformity. So it was a varus deformity, but it was almost, I mean, it wasn't truly extra-articular, but almost extra-articular. So we decided to actually do our osteotomy through here rather than try to make it more complicated, so that we got it nicely leveled up as the CT 3D this thing. So we did that. We elevated this part of the joint. We put in our bone graft, fixed this, and on the lateral side we went in, reconstructed. There was a reasonable fleck of bone which we could actually get back into the femur and fix it with a 6.5 screw and a spiked washer. And this is him at follow-up. Again, got back a good function, good stability. And again, about a year later, we took out the plate because he had some slight prominence and irritation on the medial side. But again, he had an excellent function and a stable knee at the end of it. So I think, yes, these are excellent results that I've shown, but it's not that we always get excellent results. And sometimes things are more difficult and more problematic. And here's an example where we thought we did a great job, but ended up with not so great a function. So this was a gentleman who, those were the initial x-rays. It was initially treated conservatively, ended up like that. And then someone operated on him, but was not able to do a full reconstruction. Worse than the fact that the reconstruction was not adequate was the fact that he ended up with a totally stiff knee. That was a fixed flexion deformity he had, and he had almost just a jog of movement and no other movement. And these are more difficult situations to deal with. So we went in, we did the similar sort of procedure that we had to go posteromedially, laterally, get the joint reasonably well reduced, mobilized it as much as we could, but at the follow-up, he only had about 30 degrees flexion. So we then did an arthroscopic arthrolysis. He got back around 80 to 90 degrees of flexion, but as he was having his physiotherapy, they used a little more force on it, and he came back with this fracture of the femoral condyle. And he didn't want more surgery for this, so we ended up treating that conservatively. His last follow-up, he's got a reasonable knee, but and no significant fixed flexion deformity, a movement to about adequate range of motion, but he doesn't want anything more done. He doesn't have pain, and he's reasonably happy with how he's doing at the moment. We also did a CT just to look at our joint more carefully, and you can see that the joint reconstruction is fairly good considering what he had been through, but not the best of function. So this is something you have to be aware of. These are not easy situations. They are difficult, complex situations, and you're not always going to get a perfect result. So I'm just going to go through some examples of other areas of the body where we've done these osteotomies with fairly good results. This was a young girl who came to us 6 years after the original injury, and she just reached her age where they were considering marriage, and she basically had a fixed flexion deformity of her knee about 20 to 25 degrees. If you looked at the x-ray, they didn't look very remarkable. But if you see the CT, you can see this step off in the condyle of the femur. Okay, this is on the medial side. And her problem was, this was the flexion deformity she had. Even under anesthesia, you could not straighten this. So we had decided to do surgery. Again, as you can see, she had a full range of flexion. So it's a situation where you really have to think hard. Are we going to do more harm by doing something? And obviously, whenever you're doing intra-articular osteotomies, you have to worry about that, okay? So here was, and now you can see how much worse things are actually than even your images show. So this is the anterior part of the condyle. This is the posterior part of the condyle, and a huge step off here. So it's a tough job trying to get this back. And it's been there 6 years. But I think in a young girl like that, we have to try. So again, we go do your osteotomy through the original fracture site, as you can make out. You take off this segment of sort of fibrous tissue and bone and cartilage that you have, sort of fibrocartilage that you had in this area. And then you have to pull this down and into the level of the joint. So it takes time. You have to kind of maneuver, use distractors, use sort of work gradually and try to stretch it out without disrupting all the soft tissue until we finally were able to get the condyles lined up, and then we fixed it with front to back screws. And over a period of time, she disappeared. She didn't come for follow-up for a long time till we were able to trace her and call her back. And this was her 4 years of follow-up. You can see how beautifully the joint has sort of formed. It looks clinically normal. She's got a full range of motion, no fixed flexion deformity anymore. And she's got married and has a child now. So I think so these can be quite gratifying when you're doing these for patients who would otherwise be left alone and then eventually end up with either an arthrodesis or an arthroplasty. Here's similarly intra-articular malunion of the distal radius. You can see this came to us about 5 months after, and you can see the big step off. You can see the clinical deformity here with the ulnar sort of prominence there. And here again, if you looked at it very carefully, the distal part of the radius, part of it, the posterior part was still there. So it was like a Barton's. Again, we could actually do the osteotomy through where the original fracture line was, recreate the fracture, and then gradually get this back aligned with the distal part of the posterior part, and then put in a few lag screws and then a buttress plate on the front. And again, you can see how even the radio-ulnar alignment has been restored because the posterior part was okay. It was only the anterior part that had really subluxed. Similarly, in the ankle, we get these step-offs where patients have been treated conservatively or inadequately reduced surgically, and you have to then try and do something for them. So here is a gentleman who came to us 9 months after the original injury. You can see how the fibula has shortened. So part of the reconstruction would be involved getting the fibula back to length and also getting this osteotomy and getting the joint corrected. So that's the line of the osteotomy. Again, through the fracture line, you have to get this articular surface nicely lined up, but you also need to osteotomize the tibia, the fibula, and bring it out to length. So if you look at these two screw holes, here's where you put a screw, put a laminar spreader, do your osteotomy, and then lengthen by using the laminar spreader to increase this distance from the plate. So here's the osteotomy, the lengthening, the reconstruction. Again, then it's fixed with plates, both from the posterior side. This was the reconstruction. This is him at about 7 months follow-up. Again, got back a good function and a painless ankle at the end of it. Even more complex reconstructions can be done. This is interesting. This is someone we just did recently. We do not have the follow-up on it. Again, not much you can tell on the x-rays, but it was 1 year down the line. He was complaining of a lot of pain in the ankle and gross restriction of his dorsiflexion. If you look very carefully at the x-ray, and I've actually magnified this a bit to see that, you can see there's a step off here. And again, if you look at the CT, that shows you in this section, but it's not the entire anterior part, it's part of the anterior part. So you need to then map it out, plan your osteotomy through that, then elevate this. It's like a sliding osteotomy to pull this up so that this is aligned with that. And this is what we were able to achieve. We were able to get this joint nicely reconstructed so that he was clinically at surgery. We were able to kind of dorsiflex the ankle much more than we could preoperatively. We also kept on fixator to distract the joint for some time. We've just recently removed the distractor. The x-rays look okay, but hopefully only the follow-up will tell us how well he's doing in this situation. Again, elbow is a region where we've done a lot of these. Patients come to us at various times, and I'm just showing one case in the elbow, but this is an area, again, we have a large series of them. This is an unusual case because he presented to us 13 years after his injury. Okay, he had a range of motion of 40 to 85 degrees. We asked him why he didn't have treatment earlier. He said, well, I couldn't afford it earlier, and now he's engineer, IT technician somewhere, and he can afford the treatment, so he wanted to get it done. And again, he landed up with us. He was working somewhere else in some other city, metropolitan city. And again, you have to go down, plan your treatment. I'm not showing all the CTs, etc. You need to look at them. And you can see the articular surface is looking horrible here, okay? And you wonder whether after all this much time, it's really worth doing anything. But I think if you carefully plan your osteotomy, get the joint reconstructed. Again, it doesn't look great here, but we've been able to get the joint reconstructed. You have to cut off bone here, reconstruct the sort of cubital, the olecranon fossa here, so that the olecranon can go back in the correct place. This is the lateral side being fixed, and then the medial side also was fixed. And this is him 1 year post-op. Now he's got a functional arm. Early on, he used to have a lot of pain and difficulty in lifting things. It doesn't have a full range of motion, but much better than he started with. And he's very happy with the result at this stage. So again, long-term follow-up will show how well he does. But I think at this stage, I certainly think we've been able to reconstruct it reasonably well for him to function for the next few years. This is, I think, probably the last case. This is a patient with a fracture of the calcaneum who came to us 3 months old, 3 months after the initial injury. And again, I don't think there's much literature on any of this. It mostly involves arthrodesis and extra-articular osteotomies, etc. But here was a patient where, although he presented 3 months, you could see the articular depression here still clearly on the X-ray. We got the CT scans, and again, in this section, you can see there's a nice articular depression here. And we decided to plan our osteotomy by kind of doing an osteotomy to this area and then elevating this part. And this wasn't straightforward. It's not easy. You need to, again, take off the lateral wall just as you would do for the things. There's a little bit of varus. You can correct that as well if possible. Again, you can see the sections showing you the depression. And this is the one which shows you the classical sort of depression. And the idea of the osteotomy was to actually take off bone like that and then derotate it and then fix it. So that's the approach. Again, the standard extensile lateral approach for the calcaneum. And here's was the difficult part, was to actually get to see this articular surface because it's covered by a lot of bone. You need to very carefully kind of nibble out this bone so that you don't damage the articular surface in your dissection and your approach. And then you do your osteotomy. That's the piece of bone that we got with. Now you can see now the articular surface looks reasonable. We put it back in place, aligned with the posterior, with the inferior facet of the talus, and then you put your provisional K-wire fixation. This is a void in these, and he put a couple of lag screws here to fix that. We also bone grafted the void because it was an old case, although in fresh cases, we today don't put any bone graft into this. But being an old case, we decided we should put bone graft. And we just used the simple 1/3 tubular locking plate. So 2 lag screws and this plate with a couple of conventional screws and a couple of lock screws to hold things. And this was the post-op X-ray. Again, you can see the articular surface is reasonably well reconstructed. And this is him 1.5 year follow-up. These are pictures he sent on WhatsApp. So not X-rays which he could take in the clinic. But again, you look, he's got back a fairly good reconstruction, is almost painless, and a fairly good function at the end of it. So I think even in some of these difficult situations where you feel there's very little you can do, I think there are situations where you can. I'm not saying you can help in every situation, but if you look at it carefully, there are patients who otherwise you'd think you can't do anything for, which you can reconstruct with intra-articular osteotomies. I think I'd just like to conclude by saying that I think these intra-articular malunions really need to be carefully assessed. You need to look at the clinical problem, whether there's a significant clinical problem or not. You need to look at the possibility of reconstruction. And if both these are there, I think you need to plan your osteotomy carefully. You need to deal with intra as well as extra-articular elements of the problem or the deformity. And then if you're able to carefully plan out and reconstruct the joint, I think the results are fairly gratifying, as I've shown in these series of cases. And I think what it tells us is biology is really the key. You have to be able to get these joints as well reconstructed as possible, and then nature will look after it for a long time to come. Thank you. Okay.
Thank you, John. That was a wonderful exposure to your vast experience. I know this is only the tip of the iceberg, which you could share in the last 40 odd minutes. Friends, you can ask the questions on the WhatsApp number, which you are able to see now on the screen, 9822402204. I have got only a few questions at present.
Sure.
Putting that, my own first question is, what is the oldest non-union? Means how many months or years after the injury you had treated a malunion with this type of surgery?
So I showed that the distal humerus where we did it was 13 years post injury. Okay.
Yes.
So that's the oldest we've done. In the proximal tibia, we've gone as far as 2 years, 2.5 years post injury. Okay.
Yes.
I think it depends on a few things. It depends on how bad the deformity is. There are already secondary osteoarthritic changes in the joint, how mobile the joint is, and whether you feel that when you reconstruct it, you're going to be able to get a reasonably good function from that joint. And I think it's not simple. It's and it's going to be not always that easy to reconstruct things. But so you have to look at it carefully and look at the possibility of reconstruction before you start out. I think today, one of the things which people are also doing is the 3D printings of the deformity. We haven't done it yet, but I think the 3D CTs we've done well, give you a lot of information, but 3D printing could be something for the future where you're able to see things a little more clearly, and then you can maybe plan your osteotomies a little bit better.
Okay. Yeah, there is a question from Dr. Milind Survade from Malad, Mumbai. When do you choose to go for medial epicondylar osteotomy? How does it improve the visualization of the medial plateau? And because the medial collateral ligament is adherent to the medial meniscus, so after osteotomy, also the meniscus is going to come in the way. Can you elaborate this more on this approach for posterolateral tibial condyle?
Yeah. So this is something that you have to look at. I think what happens is if you need to dissect out the medial collateral ligament, once you do your osteotomy, clearly dissect it off from the periphery of the meniscus. Okay. And then once you do that, your visualization becomes, so how does it improve the visualization? I think that's really amazing because you can see the entire medial plateau. If you saw the x-rays, and you can look under the meniscus then. What you do need to do at the end is to repair your meniscus. Okay. So you put in non-absorbable sutures into the soft tissue on the tibial side, as well as onto whatever soft tissue you have on the femoral side if possible. But mainly onto the tibial side, you can suture onto the medial soft tissue that you still hopefully preserve when you're doing it. So you have to dissect out the ligament very carefully off the medial meniscus in the periphery and then repair it. It's not something you want to do unless you have to. So I think if you can approach it from the back or the front, but sometimes the depression is right in the middle, right behind the right where the medial collateral ligament is, and it's very difficult to really visualize it, especially in the old cases. In fresh cases, you can work on either side of the ligament and elevate it and fix it. But here you have to do your osteotomy through the previous fracture where possible. And it's impossible to really do it without you getting a good visualization of that area.
Yes. Okay, there is a question from Dr. Kitu Kumar. Sir, the conventional X-ray is better than the digital X-rays. First question, because you always show conventions X-ray. Probably these are the earlier X-rays. In which cases of osteotomy do you use femoral distractor, and how importance would you give to the posterior slope of the tibia?
Okay, so digital X-rays or conventional, I think most of them now are all digital X-rays. So you don't get conventional X-rays anymore.
Yeah.
I think the only advantage of conventional X-rays over digital X-rays was that you got them in a standard magnification. Today with the digital X-rays, you can get them in various shapes and sizes. So if you are planning your X-rays, you ask them to give you 1:1 or the standard magnification images. So that helps you with your planning. Okay. So distractor, wherever you feel that you need more space, okay,
yes,
you would use a distractor. Okay, so sometimes, especially the older the cases, the more likely you're going to need a distractor. However, you have to bring a part of bone which is outside the joint into the joint. That's where the distractor really becomes important. Posterior slope of the tibia. So we are talking about not the entire tibial condyle, but parts of the tibial condyle. Okay, so what you're doing is trying to match this fragment to where the other fragment is. So usually the slope in itself is not such a big problem. Obviously, it's important in real life, but you're dealing with a situation where if you leave it alone, it's going to be a total disaster. If your slope is off by 1 or 2 degrees, it doesn't make that much difference. But your aim, you're actually aligning it. So if it's a posteromedial condyle, when you elevate it, you're going to align it with the lateral side as well as the anterior side. So your slope doesn't really change dramatically. So the slope is also usually reconstructed when you're doing it.
Yes. Okay. The next question is, does cartilage also rejuvenates?
Yeah, so that's the beauty of it, because I think we always sort of talk about and are taught that if cartilage stays out of the joint for 3 months or 6 months, it's going to disappear, etc. But surprisingly, we've found cases even quite late where we've been able to, once you get things back into the joint, you get the biomechanics sorted out. The cartilage seems to, I'm not going to say it's going to be beautiful hyaline cartilage as before, but it kind of heals with reasonably good fibrocartilage. After all, when we do HTOs, we've seen how the medial joint space actually improves over time in some of these patients. We don't, as a routine, go back and scope all these patients in the proximal tibia, but the ones we have done, for whatever reason, for arthrolysis, etc., the joint looks reasonably good.
There is a question. Can you please elaborate the tips and tricks about chronic malunion of bilateral Hoffa fracture with a stiff knee?
That's like the whole day's question.
I know.
So Hoffa's, again, first is the most important thing in Hoffa is not to miss it so that you don't get the malunions. Then you have to see where the malunion is, where the plane is. And if it is bilateral, you're going to need a bilateral approach. So you can do the parapatellar approach on one side, but usually if you have to do both sides, you really need 2 approaches. So I would, in those situations, depending on where the fracture line is, plan my incisions accordingly. So it could be a submeniscal, a subvastus approach on the medial side and a parapatellar on the lateral side, or the other way around, go more posteriorly on the lateral side and parapatellar on the medial side, depending on where the fracture line is and where it will give you the best visualization and where you can fix it best with. Now, it depends. We have quite a few cases of Hoffa malunions which we have treated, but it would become just too long, and I thought people would get exhausted by the end of it. But so again, now how you fix it would depend on the size of the fragment. So if it's just articular part, then usually all you can do is front to back screws, and sometimes you can put in bigger screws from the posteromedial or posterolateral side across, and here you can use 6.5 millimeter screws with washer across to the opposite anterior side. So you start posterolateral, end anteromedial, or vice versa. Okay. If you have a Hoffa with a sort of spike of bone, which is going on to the metaphyseal part, then it's nice to be able to buttress that corner. And usually this is posteromedial or posterolateral. So you need to put your plate which will buttress that posteromedial or posterolateral corner on top of your lag screws that you put in. And the ones within the articular area, you'll need to countersink. There are various options. You can use 3.5 millimeter screws, or what we use are the 3.5 millimeter locking head screws, which are much easier to actually countersink in because the hole you have to make is much smaller. Okay?
Yeah, that's fine. The next question is, do you release MCL from the medial tibial condyle while elevating the medial tibial condyle?
So again, like I said, it depends on your approach. Okay, so if you're doing the medial epicondyle osteotomy, then obviously you're releasing the MCL completely. If you're going posteriorly, like the case I showed with a posteromedial fragment only, there we went from the back, worked through the original fracture line. So there we didn't do anything to the medial collateral ligament. So you can do a posterior approach and do that. So all depends on where the fracture line is, how much visualization you need, how much you can work through the previous fracture line. So the older the cases go, the less likely you are to be able to see the original fracture line, and there it becomes more important to do the medial epicondyle osteotomy. Also, depending on where it is. So if it's posterior, it's easier to go from the back. If it's more anterior, you can go from the front. But when it's right in the middle, it becomes a little more difficult to do that.
Okay. How frequently is MRI done as a part of pre-operative planning? This is Dr. Shashikant asking this question.
I think you have to assess patients carefully. So when you examine the patients, you need to look for any obvious laxity, etc. And if they also have ligamentous laxity, so when you examine patients, you can tell whether, and look at the X-rays and CTs, you can tell whether the laxity is because of a depression or there's actually opening out of the joint on the opposite side. Okay, and if that is there, then it's useful to get an MRI, because even though you may not deal with the ligamentous problem at the same time, you need to plan and tell the patient, okay, you're going to do this, but you may also need a ligamentous reconstruction. Yes. So we are also doing, so some of the cases we are actually combining ACL reconstruction with the osteotomies, etc. Becomes a little more complex to do. So I do that with a sports guy, and we've done some of those, but most of them, or if they're bony avulsions, then we deal with them at the same time. But pure ligamentous, so if the PCL is gone or ACL is a sort of ligamentous tear, sometimes we'll do the osteotomy first and deal with the ligamentous problem later. But it's good to know about it so that you can tell the patient that he's going to need an additional procedure later.
Yes. Dr. Somnath Ghatak wants to know, what bone graft substitute do you prefer? Okay, so again,
this is not something, so what we use is our calcium sulfate. Okay, so usually it is either Kronos. We sometimes use one of the other ones that are also available. So I think it's good to use stuff that you can rely on because there's some quality control, but I don't have a sort of any particular. So we've used some of the pastes, etc. But probably that's the one we use most often.
Okay, Dr. Dayanadi wants to know, if there is a central depression with intact tibial margin, what is the approach? Can tibial tuberosity osteotomy helps?
So this is I think if you read Dr. René Marty's book, so he actually describes osteotomy where you do a submeniscal arthrotomy to be able to visualize it. And then you actually make multiple drill holes through a cortical window and then elevate this central sort of circular part up. What I find is better is to actually make a lateral cortical window so that you can visualize it better. So it depends on, so if the lateral sort of margin is more or less in the correct place and it's a central depression, you can actually osteotomize the lateral side, and then that gives you a direct visualization of the depression. And it's much easier to then do your osteotomy and elevate the part. So these are one of, so I don't do a tibial tubercle osteotomy for these. Of course, if you do that, you're again going to visualize things better. But I think fixing the tibial tubercle when you've taken it off all the way, getting a good secure fixation is not that easy. And then you have to delay your mobilization and things.
Okay,
So
there is one more little longer question, means the answer will be longer. Steps of pre-operative tips, if any, and tips for taking so nice per-operative pictures. Dr. Sumant Sinha from Delhi. Steps of pre-operative tips.
Okay, so I think what I mentioned earlier is that you need to assess patients carefully in terms of their symptoms, their clinical findings, and then do the appropriate investigations. Okay, so get good quality x-rays, we always get, especially, so let's again concentrate on the tibia. We get the long length limb alignment views. So hopefully you should have the ability to get those done. I think you can either have the long cassettes, or today with the newer sort of software, you can stitch images together and do it. So it should be possible in most places. I know it's difficult. We don't seem to get them from most places, but I think you have to talk to your radiologist, talk to your X-ray department, and get them to do it. It's a little expensive to do, apparently, for them to get that cassette, etc. So they try to avoid it. But I think if you're dealing with deformity correction, especially in the lower limb, then it's absolutely vital that you have these long limb X-rays. Yes. Intraoperative photographs. Okay, so we have a guy who does them. Not always good. I think I've shown you a selection which show up well. There are many which we see and don't get as good images. So we are using a standard digital camera, nothing very fancy. You just need to make sure that the light, so especially with the LED lights today, it's a problem. So you need to reduce the light in that area and then take the films and then check that the films are correct. Okay. So very often you find you've taken all the films and you go back and look at them, you can't see anything. So the idea is to make sure you look into that camera with the guy who's done it and actually see that the picture has come well. Otherwise, repeat it till you get a good picture. I think this is one of the things that happens where we haven't done it, and later on you find that what I want to see is not really visible. Okay.
Yeah, that's correct. Dr. Nitin Patel from Islampur, Sangli wants to know, what do you do to the pes anserinus before posterior medial osteotomy?
Okay, so in fresh cases, we slide a plate under the pes. Okay. Yes. But in some of the old cases, we may actually divide the pes and reattach it. It depends on how easy or how difficult or how much it's getting in your way. Okay, so in fresh cases, we almost never divide it. Some people even divide it in fresh cases and reattach it, but we almost never do that. But in some of the old cases, if you find that it's really getting in your way, you can divide it and then reattach it later. Okay.
Yeah. Dr. Satish Nesri wants to know, does you release MCL while elevating the osteotomized medial tibial condyle?
So again, it depends on what approach you're using. Okay. So if you're using your sort of medial epicondyle turn down, then your ligament is already there down and your approach is there. When you're doing a posteromedial fragment and elevating it, you need to free the fragment adequately. So this medial collateral ligament doesn't really, get in your way when you're elevating this posteromedial ligament, okay, fragment. Just as when you're doing fresh cases, once you osteotomize it and loosen it up, then it's like a fracture fragment that you're getting reduced. Okay. Just takes longer and more difficult. You use distractors, etc. I think it takes time. It's not something which you can do in it. You have to spend time, check it, elevate it, put in wires, look at it on the C-arm, Sometimes it's not okay. Then you take out the wires, do it again. You have to do it. Sometimes you wonder why you're there. There are cases where we've done where they've had multiple previous surgeries and you wonder why am I taking this headache of doing this when, but I think if you start doing them well and you see the results, that is really something that will keep you doing them.
Yes. There is a question from your city colleague, Dr. Shivpuri from Patna. He wants to know what is the approach you prefer in posterolateral tibial condyle fractures.
So these are for fresh fractures?
He has not mentioned. Yes.
Okay. So fresh fracture. So again, it's not, so this is again almost an entire lecture, but it depends again on the fragment, the size of the fragment, where it exits, etc. Okay. So the approaches are there. You have the posterolateral approach without the osteotomy. You have a posterolateral approach with the fibula osteotomy. You have the Frosch approach where you part of it is the posterior approach and the anterior window where you can put a lateral plate. So it's a kind of curved incision on the starting posterolateral and ending up anterolateral. And the same kind of incision with a fibula osteotomy. I think in terms of visualization, definitely the fibula osteotomy is best, but then you have the problem of dealing with the common peroneum and fixing the fibula. So people avoid doing it, but where you really need best visualization, that's the best. There are some other ways where you can put rim plates. There's one described by Dr. J.K.O. from South Korea, from Seoul, where he dissects under the lateral collateral ligament from the anterior, goes across to the back, bends up, curves a plate, and then puts in screws through that plate and compresses across it. It's technically a little difficult to do, but something you can think of if you want to avoid a posterolateral approach separately.
Okay, I'll take one or two more questions before we start the next talk. Dr. Gurdev Kumar from Patna wants to know, complex comminuted fractures of proximal tibia with good amount of bony avulsion, both ACL, PCL. So how to catch the avulse fragment during the plateau fixation? So central avulsion of the tibial spine with ACL, PCL.
Yeah.
So can you catch with the fixation?
So, okay, so this is like, yeah, so sometimes you can, and sometimes it's more difficult. Your approach is important. You need to be able to first visualize it. We have used a number of techniques. We've, in a really large fragment, we've actually tried to catch it with a screw from underneath, but the avulsed fragment with the ligament, we have used sort of, again, I get my sports colleague in and then Dr. Arvind, they use the techniques of repair of ACL or the anterior tibial spine and put these sutures through and bring it out on the medial side. Okay, so
yeah,
using that, what do you call that, basket? No, what's that?
Your internet is a little dicey.
Okay.
Yes.
It'll get better. It's kind of goes through that phase.
Yes.
Okay, is that okay?
Yeah, that's fine. Dr. Milind Joshi from Solapur wants to know, in which elbow, in the elbow case of 13-year-old non-union, what approach was used?
So we did an olecranon osteotomy there. So I think if good visualization of the articular surface, it helps you to also mobilize the joint because you can actually do an arthrolysis all the way around to the front with that. The thing to be careful of is you're doing your osteotomy is to make sure you don't put your saw straight into the condyle. So make sure you've cleared out the joint, put in some hemostats across the olecranon, and then do your osteotomy exactly where you want to, and not go with your saw straight into the condyle and damage that. And once you do that, you get a very good visualization.
Yes. Subbu with his name, Subbu Live and Let Live is a pet name. He has asked the question, in cases where osteotomy with ligamental reconstruction is planned, which in a single sitting, which is done first? Whether you do the osteotomy or the ligamentous reconstruction. I think it's the osteotomy.
Yeah. Always the osteotomy, because you don't want to be then, once you've done your ligament, you don't want to be pulling and pushing in different directions. Yeah,
that's correct. Then Dr. Janaki Saran Badani wants to know, your views on healing of articular cartilage after osteotomy and damage of cartilage. I think we have already answered that question. Yes. Yeah.
My views, I don't know, but it seems to work. That's all I can say.
Yes. Once the joint is aligned, at least
Yeah.
some cartilage is found. If not hyaline, at least fibrocartilage, that is reasonably good. Yeah. Then how do you protect the saphenous nerve with proximal tibial posteromedial approach? You can start sharing your screen also meanwhile. This will be the last question.
So posteromedial approach, I think the saphenous nerve is more of a problem more anteriorly, okay, because it comes more anteriorly by the time you're in the proximal tibia. So it's actually branches of the saphenous nerve which you can damage with your medial parapatellar incisions, etc. So when you're doing a posteromedial approach, you're actually going behind the posterior border of the tibia. So the saphenous nerve as such doesn't come directly in the way, but you need to watch and make sure that you're not cutting it when you're doing your superficial dissection. I think it usually doesn't come right into your area of dissection, but whenever you're doing your skin and superficial dissection, make sure there's no nerve or vein, big vein that is coming in your way. Okay,
okay, you can start the next part of your talk.
Is that visible?
Yeah, yes.
Okay, great. So I think this is a few things that I want to kind of just bring out, because we all have, I think any trauma surgeon who's doing surgery is going to have complications. There's a huge potential for complications, and every patient is different and every injury is different. You get unexpected complications and you get expected complications, and they can happen in almost every stage, can lead to increased morbidity as well as mortality. And when patients die on you, unfortunately, the repercussions can not always be they can be very unpleasant. And also they have major financial and social implications for the patient when things go wrong. Okay, so how do you avoid complications? I think really the best way to avoid them is to try and anticipate them. And that means you need to start looking at each patient, and when you're thinking of the treatment, at every step, think of what are the possible things that can go wrong and then try to avoid them. And these could be a number of things. It could be in your initial assessment and management. And this is where in the seriously injured patient, your critical care colleagues become important. In your assessment of patients, it's important to try and miss injuries. I think we've all experienced cases where you see the obvious fracture and then there's some fracture somewhere else that you've totally missed in the initial assessment, and sometimes even after treatment. I mean, we've all done it. I've missed an acetabular fracture, of fractures of the phalanges and metacarpals and metatarsals are something very often which are overlooked and sometimes can be what bothers the patient at the end of your treatment. Of course, intraoperative complications is something you need to watch out, systemic complications, and I'm going to touch a little bit on that, local complications with wound healing, etc., and of course, failures of fixation. So I'm not going to go everything, but just look at some of the things which I think we've learned over a period of years and hopefully are able to reduce the incidence by being careful about it. And these particular slides are from the AO archives, but this is something which all of us would see in our practice at some stage. You have a young patient who looks perfectly okay. He has a femoral shaft fracture, he's stable, his pulse, BP, etc. is okay. And you take to T, and suddenly either before, during, or after surgery, he ends up with having severe respiratory problems, up in the ICU, intubated, and then may or may not recover from it. Okay, so this is a problem which has always bothered me from the beginning. For many years, we lost a couple of patients, and we actually lost one patient with a bacterial fracture who suddenly went into
John,
what
can I
we
disturb
call...
you for a minute? John, if you can close your video, you can just
Okay, it's the thing. Yeah, sure, I'll do that.
Yeah,
No
your
problem.
voice is getting cracked.
Okay,
That's
what's
all.
happening here?
On the left side
I'm
button,
not
there is
getting.
no, on the
Stop.
left,
No, I'm not. That button is not coming.
there is a stop video button, left side down in the Zoom.
I know
Not
that
there.
usually is there, but somehow it's not coming at the moment.
Okay, probably your stops. You have to stop screening for a minute.
Maybe, okay, I'll do that
I
and
can do
stop.
that from here.
Yeah,
Okay,
okay,
can you
then
do that?
yeah. Yeah, you can continue, John.
Okay, so now you wonder what is this? Is it fat embolism? Is it some chest injury that you missed? Is it your timing of surgery? I remember we all used to be taught at one time is in femoral fractures, don't operate between the second and fifth day and things like that. Is it pulmonary embolism? Or what is really now become more clear is that these patients have problems mainly because they haven't been resuscitated adequately before surgery. I think this is the important thing that when we look at these classical signs of shock, they are not always reliable after the so-called golden period. And you may have inadequately resuscitated the patient, but you don't have clinical signs of it. And this is what is known as the occult hypoperfusion syndrome. And once you have this, the clinical signs are unreliable. You have to rely on subtle signs like slight confusion or disorientation. Sometimes it's drowsiness. It might be just mild tachycardia or tachypnea. And in a young patient whose normal pulse may be in the 50s or early 60s, his pulse of 80 is tachycardia, but you think 80 is a normal pulse rate. I think it's important when you're dealing with these femoral fractures is to always check the pulse oximetry. I think this is an easy thing to do. And if there's any problem going to happen in terms of ARDS or if fat embolism or something like that, this usually will be an early indicator because the oxygen levels in under room air will always be not the normal, which for a young adult would be in 98 or 99. And you'll find it's 92, 91, 93. It may be adequate for him not to have symptoms, but gradually over a period of time, this hypoxia will affect the tissues and then lead to what we call the systemic inflammatory response syndromes. And you have the inflammatory markers, okay? So you have IL-6 and you have some more fancy ones, but the one that you can do easily in most situations is a serum lactate, and most blood gas analysis should have this. And I think it's important again in these to just check these before you plan on surgery. Okay, so it's not the days, and I'll show you some evidence for it, because what happens to these patients is they have this second hit with surgery. So with the first insult, they get a moderate systemic inflammatory response. And with the second hit, which could be the surgery, could be infection, they develop a more severe systemic inflammatory response syndrome. And that leads to all these complications such as acute respiratory distress syndromes. You get further infection. Eventually, if things are really bad, they will end up with multi-organ failure and end up in problems. And there are now numerous studies which show that if your lactate levels come down to normal within 24 hours, then the chances of mortality are low. If they remain elevated for more than 48 hours, then the chances of mortality are very high. And even in solitary femur fractures, the results are directly correlated to presence or absence of occult hypoperfusion rather than the timing of surgery. Okay, so this study actually looked at various patients having just femur fixation. 27 of them had all their parameters normal before they had their fixation, while 20 had things like occult hypoperfusion with increased lactates, etc. And then they looked at what the sort of problems that they had in these patients, etc. And you look at the two, it's obvious that the patients who had occult hypoperfusion or elevated lactates, they have much more complications and much higher infection rates as well as ARDS, etc. And a huge difference in hospital costs as well. So I think it's critical in these patients, even if it's a simple femur fracture in a young, especially in young patients. And this is classically in the young adult more than in children or in elderly patients, because often, especially in our country, they've had the injury, they haven't been splinted adequately, they can bleed a lot into that area. They've sometimes traveled for miles before they've got to you. but it's because their homeostatic mechanisms are so good. Their clinical features still seem that they have no serious problem. And you do something to them in that situation without adequately resuscitating them or getting their lactates and the oxygen levels back to normal, you're going to end up in problems. Now, when it comes to failures of fixation, I think you all know about this triangle of issues between the patient, the fracture personality, and the surgeon. And if we look very critically at most of our own cases as well, you'll find that more often than not, you could have done something better, which might have prevented the failure that you had. I'm just showing you a few cases which came within, I think, 2 or 3 days to my clinic. This is some years ago. This was, and I saw these within 2 days, believe it or not. This was a distal humeral coronal plane fracture. This was what was done to it. This was a proximal femur fracture. This was what was done to it and ended up like that. And on top of that, had infection by the time they came to us. This was a clavicle fracture, which might have been treated conservatively. This is what it landed up with, and this kind of horrible clinical deformity with the plate there when he landed up to us. This fracture of the proximal tibia was operated once, reoperated a second time, and these are, some of them are from metropolitan cities, not just from Patna or Bihar, but from metropolitan cities around the country. They've been operated on once, twice, sometimes even 3 times. This was within a period of 2 days that these 5 or 6 cases landed up with me. And here a more complex problem, maybe it can't be so critical, but you can see there's definite valgus in the tibia and in the femur. The chances of that implant failing again are very high. Now, why does this happen? Is it because of poor training, poor infrastructure, something wrong with our system of education? Do we not have adequate quality control of what people are doing? Or is it something more sinister and grave, like surgeons not really worrying so much about their patient? Is it apathy? Are there mercenary factors? And we really don't know. And certainly don't feel that, I feel that 95% of surgeons would not do something deliberately wrong for their patients. But you can make mistakes, okay? And this is where we have to start looking at our training. And again, this concept of cognitive ergonomics. And this is where you need to try and improve your skills, not just in terms of your technique, but how you do your technique, how you think about your technique, and how you are thinking at every stage of your surgery. So these are trying to improve your cognitive skills to avoid errors in your surgery. And they've done this with surgeons, they've done it with biliary surgeons who sometimes end up with problems. And I'd like all of you to look carefully at this video. Some of you may have seen it before, but try to count the number of times the call has been passed. Okay, all of you have seen this, but so honestly, those who haven't seen the video, how many of you actually noticed? Just watch it again and look for this bear walking across. And dancing as well. Just shows that when you're concentrating on one thing, it's very easy to miss something else that you're not looking for. And this is used as a public awareness thing, training drivers to look out for cyclists when they are watching it. So I think this is some of the reasons why problems happen during surgery. It could just often be just a momentary loss of concentration. Here's an example from one of our own patients. This was a comminuted fracture of the humerus, and someone can argue whether you should plate it or nail it, but it was decided to nail it, and everything looked good. At this stage, you seem to have got entry into the distal fragment, but just watch the subsequent sort of X-ray. I was called in later when this problem happened, but I'll just show you when I went back and watched all the images. You just watch it, 1, 2, 3, 4, and that's what it ended up as. And I think it's just one moment's lack of concentration sometimes which can end up with disasters. And again, so we had to kind of deal with it. We kind of then decided to change to a locking plate fixation. And luckily, this lady did well and had a good result, but you can end up with a disaster. Similarly, another case, this was a simple nailing of the tibia. Everything went well. But again, you should know your implant. Okay, this was interesting because this was a standard tibial, the old UTN as it was called, the unreamed tibial nail, but which has an entry normally at the top of the tibial tuberosity. But you know, the newer nails have this more proximal entry, and the surgeon used that entry without thinking about which nail he was putting in. And then when he went to put in the end cap, he missed the nail and ended up here. And then it was a real struggle to get this end cap out. So all sorts of things, 70 minutes and 300 images shots later that he was able to recover this fragment and then go on to complete the fixation. So just moments of a lack of concentration can end up in situations which end up in trouble. Here's a patient we had to actually operate on recently. Was the original X-ray was nailed, and I think most of us will agree that it looks okay. Maybe you should have locked double on two locking on the distal, you can say that. But again, look very carefully at the distal locking. It's there in the dynamic hole, but it's an area where there's no room for this to dynamize. And this being a slightly oblique fracture, eventually this screw broke. It self-dynamized a great extent, but it became unstable and did not heal, and then we had to do something. So sometimes what looks like a very minor sort of problem can end up with major consequences. So there could be many reasons for failure of fixation, and it's best to try and prevent failure by getting things right the first time. And again, here, planning carefully, thinking about your steps is important. And also it's important to communicate to patients where you have difficult situations. If you feel you're not able to do a good, a perfect reconstruction, or it's something that you think you'll have problem with, it's a good idea to communicate with your patient as well. The other areas, mainly in proximal and distal tibia, is the soft tissue consideration. I think this is, again, one of the most important lessons we've learned is don't ignore the soft tissue, because you'll end up with disasters, and you ignore soft tissue at your peril, especially in the proximal and distal tibia. And there's again a case who we had to deal with. Originally, this was the X-ray. If you look at this X-ray, you may not think how bad the injury is, but if you look at the original X-ray that was there, see that. Okay, so very often when the X-ray is being done, the radiographer may pull the limb, get it provisionally reduced, and if you just see this X-ray without looking at the previous X-ray, you may miss the extent of the injury. Anyway, this patient was treated elsewhere. He had this kind of plating, ended up with a problem with compartment syndrome, and he came to us a month later. Okay, there was no movement, no sensation, and again, if you look closely into the muscle here, it's all dead muscle in the deep compartment. So we ended up having to amputate his limb. Similarly, this patient was operated on 2 days after his injury. That's what he ended up with. All the soft tissue sloughing off, came to us more than a month later, and again he ended up with. The last important thing is, I think, this concept of preoperative checklist. I think this is now something which I hope all of you are doing in your practice. I think it's the WHO list, which you need to look at patients coming in for surgery, not just once, twice, but 3 times. One is when they come into OT, and that is with the anesthetist and the nurse, etc., where they look at all the identification marks, the site, the anesthetic preoperative checklist, the pulse oximetry is on the patient or not, medical history, any allergies, any risk of blood loss, is blood loss, if there has blood been grouped and cross-matched, etc. So this would be the first part. The second part is after draping and before you actually make your incision, you have what they call a surgical timeout. And again, confirm with all your team members. So that's just not you, the surgeon, the anesthetist, as well as the theater personnel, the scrub nurse, and you need to check on all the things, your equipment, your C-arm, blood, all these things, whether the antibiotic has been given at the appropriate time, etc. And again, before the patient goes out or before you even close, you need to look at things like swab counts and instrument counts, check everything again before the patient goes out of theater. And it's important because they actually did a study on it, and it's interesting that it's an Indian surgeon, Atul Gawande, who was one of the people at the center of this, where they worked on 8 centers across 5 continents, including teaching hospitals in the UK to rural hospitals in Africa. And there were 7,688 adult patients that they looked at. There were 3,733 before the implementation of the checklist and 3,955 after. And if you looked at the results, it's quite sort of staggering, because they could reduce major complication rates by 36%, that is from 11% to 7%. They could reduce deaths by 47%, that is from 1.5% to 0.8%. And they could reduce infections by half. And if you looked at mortality rates, and if you look at the number of surgery that is done worldwide, which is 234 million roughly, it would save 1,638,000 lives if you just do something like a checklist. Just think about the consequences of that. And this is something which is important. I think it's something which is passed on really from the pilots, where they always have to do a checklist before they fly a plane. Doesn't matter how senior or how experienced they are. And it's important to do this. And unfortunately, even where they have these checklists, it's, I think, rarely, or at least not as often as it should, that the surgeons and the anesthetists and the scrub nurse actually go through these carefully. I think the Hippocratic Oath is that first, do no harm. I think more to the present is the Declaration of Geneva for medical practitioners, is that the health of my patient will be my first consideration. And if you have this in mind, you will do your best to try and avoid any complications. So I think what my message would be, that I think complications and trauma are sometimes inevitable. Okay, I think there's no way, no one who's that good or that perfect that he cannot avoid complications all the time. However, we must do our utmost to try and avoid it. And this means a lot of planning, a lot of careful thinking about what you're doing. And the best way to try and avoid it or reduce it is to actually anticipate them. Thank you. Okay.
Thank you, John. That was an excellent philosophy you had given about checklist and how to avoid minimize complications. I think you can switch on your video now. Ashok, you can switch on John's video.
I can do
it, sir.
Yes, there is a first question from Dr. Sunil Chaudhary, who wants to ask about the earlier talk. What do you do with a damaged meniscus?
Okay. So the most common situation where you see a meniscal tear is in the split depressed fracture of the lateral condyle, where the meniscus has gone into the fracture. So it's a peripheral avulsion with the meniscus getting trapped into the fracture area. So as a rule, when you're doing your lateral approach, always do a submeniscal arthrotomy. Okay?
Yeah.
And when you do your submeniscal arthrotomy, and you take your bites on the periphery and the meniscofemoral ligaments, hold them with sutures and look inside the joint. If the meniscus is there, you will see it on the undersurface of the femoral condyle. If it is ruptured and displaced, you will be looking straight into the femoral condyle. Okay, so then you have to look for the meniscus. It could be in the joint or it could be trapped into the fragments. And we see this very often. I think it's much more common than I think literature. We see it quite often because we are looking for it. We hopefully don't miss it. And then you need to because these are peripheral tears, you repair them. Okay, so you bring out the meniscus, put in 3 or 4 peripheral sutures onto it. Okay, onto the meniscofemoral part of it. And then at the end of it, you put in sutures across from there onto your plate or whatever soft tissue anteriorly and posteriorly you may have, which you can suture it onto. Okay, I think this is important. Medial meniscal tears are less common. Again, these you don't actually visualize during surgery. So I think these are less often picked up. I think they're definitely less common because of the nature of injury, because it's more usually just a split and a depression of the medial condyle rather than a sort of complete separation and comminution with a hole in the middle of the lateral condyle.
Yes. Okay, there is one question from Dr. Noor Akhtar from Purnia. His question is, when you take a patient, he has got signs of fat embolism like petechial hemorrhage after giving spinal anesthesia, what should be done? Whether to continue with the surgery or postpone it for a later date?
So I think if you discover it before you're doing your surgery, you would be safer off not doing major surgery, maybe just put on a fixer or something like that. Okay. Because if you're then going to into the canal and reaming things, you're going to cause more problems. So if you do find yourself that you're already in OT, you've already given anesthesia, then I would just put on a fixator, and that takes 5 minutes. You put in 2 pins into the femur, 2 pins into the proximal fragment, 2 pins into the distal fragment, and just connect it. You're not looking for reduction or etc. You're just looking for stabilization, and then he needs to go to the ICU and be looked after there till he gets out of this situation. Okay, so he needs supportive care in the ICU after that.
Yes. Ashok, if you have any question from in your inbox, you can ask. Meanwhile, I'll ask a question. If there is a fracture tibia, fracture femur, and fracture neck femur on the same side, how do you proceed? This is totally unrelated. Yeah.
Okay, so you're talking about shaft tibia or proximal tibia?
He is not given fracture tibia with the distal femur as well as proximal
so
femur.
Again, so patients like this, first you need to assess them in terms of their resuscitation. Okay, so you make sure that they're adequately resuscitated and whether they are safe for definitive surgery. And that is your first step. Now, how you treat your ipsilateral neck shaft fracture to some extent depends on the fracture. Okay, because the neck shaft fracture of the femur, very often the proximal fracture is minimally displaced or not displaced at all, and the shaft is grossly displaced. Okay, so that's a situation where you may consider doing a recon nail type of fixation where you put one implant to fix both fractures. Yes. If your neck or your trochanter is grossly displaced, that's a situation where I would like to use 2 separate implants. And the most common combination is a distal femur nail and something like a DHS for the proximal fracture, or cannulated screws if it's a neck fracture. Now, your tibia, you decide. If it's a shaft fracture, then when you're nailing your femur, you can use that same approach to also nail your tibia. Yes. But all these are in condition that the patient is adequately resuscitated and stable, and the anesthetist gives you the go-ahead to do more surgery at the same time. Okay?
Yes. What is the role of lactate in polytrauma?
Okay, so I think so the lactate is a surrogate marker. Okay, so whenever patients have major trauma, and major trauma means a certain amount of blood loss and more in an open fracture. Okay, so what happens is initially you may have tachycardia, your blood pressure may go down, but with a little bit of resuscitation, that comes back resuscitated, and his tissue are not getting enough oxygen. Okay, so what tells you that is 2 things. One is acidosis, and the other is the lactate levels. Now, there are other more sort of sophisticated markers like interleukin 6 and recently some others, but those are expensive and difficult to get. But serum lactate is the simplest one that most people use all over the world to judge whether your patient who's come in with major trauma, how ill he is and how well you are resuscitating him. Okay. Excuse me.
Ashok, I think Ashok is not available.
I'm here, sir. I have
Yes,
sent you
yes.
questions, sir.
Okay, because yes. Stage procedure in double plating of proximal tibial fracture to do after another, or do one to one after other. Is it safe in some situation to do like that, or safe together to do it differently in time interval,
Okay, so I think the
like
time,
double plating of the proximal tibia?
okay, so the time we wait is actually before the surgery. Okay, so
Yeah.
if you have a proximal tibial fracture with significant soft tissue injury, you need to wait for the soft tissue to settle down before surgery.
Yeah.
Now, the ideal treatment in this period is to put them on spanning external fixators. I know practically this may be a little difficult in where you're working. So you can use something like a slab or traction and wait for the soft tissue to settle down, but you have to wait till all the skin, blisters, etc. have healed and the skin starts to wrinkle. That means the classical wrinkling sign. And then it is usually safe to operate. Now, if you have a fracture that's grossly displaced, or if you have a lot of swelling and blisters, then it is definitely better to put on an external fixator. Okay, in less displaced fractures or where you have swelling and not so much in terms of blisters, maybe a slab or something like a traction is okay.
Yes.
Okay, so then you have to wait. And then if you wait long enough, then usually you can do your double or triple plate fixations adequately. If for some reason after that, when you're closing your wound, you find there is tension, don't close your wounds. Keep it partially closed. Today you have back therapy or negative pressure wound therapy. You can delay your closure or split graft it rather than close the wound under tension. Okay?
Yeah. Then Dr. Kishore Kumar wants to know on which day after trauma we would be doing nailing or plating for shaft of femur or shaft of tibia.
Okay, so like I said, it's not the days, but whether the patient is adequately resuscitated or not. Okay.
Okay.
So patient could be okay the first day.
Yes.
He may not be okay the first day. Okay, so this study which I quoted clearly shows that your complications are related to whether the patient has been adequately resuscitated at the time of surgery or not. So if we talk about fat embolism, okay,
Yes.
we don't even know if it is fat embolism that kills these patients or makes them unwell. I mean, when you're doing reaming for non-unions and osteotomies and whatever, when you're putting a nail into a femur, you never get the fat embolism syndrome or ARDS, okay? Why do you get it in acute trauma and not in... You're still reaming the same fat is going into the circulation. If you do your transesophageal ultrasound, you'll still see these flat globules coming into them. The reason you get this problem is because of the occult hypoperfusion syndrome leading to a systemic inflammatory response syndrome, which then primes the tissue in the lung, the alveoli, to then react in that way. Okay, so I think this is what you need to understand. It's not fat from the marrow that causes the fat embolism syndrome. It's the fact that you're doing major surgery when the patient is not resuscitated. And you can get it with plates, leave alone nails. But yes, when you're reaming and for a nail, you're actually putting in more marrow into the circulation. But even with a plate, you can have the same problem.
Yes. So there is one question from Dr. Ashwini Gaurav from Patna itself. What's your opinion on polytrauma case with multiple upper limb fractures only with stable vitals? Whether to go for damage control orthopedics or early definitive management? And he has given same question with two clinical setup. One is mid-shaft humerus fracture and forearm fractures without any involvement in the joint. Another clinical setup is with in situations like fracture associated with the shaft of the lower limb.
Okay, so again, it's not so much the upper limb or the lower limb that is the question. It's a question of what is the condition of the patient in terms of blood loss and his resuscitation. Okay, so obviously the upper limb, the chances of getting these problems are less. If it's isolated upper limb, it's unlikely that you have all these problems of sort of systemic inflammatory response syndrome. But if you have it with the lower limb, definitely it is an issue. So you need to go the same way. So here you may have to decide between whether you need to do temporary external fixator for the lower limb. Upper limb, usually you can splint in slabs or something like that, wait for things to settle and then do the surgery. Of course, if you have anything like a compartment syndrome or an open fracture, then you need to do the sort of emergency part of that surgery at the earliest.
Okay. There's one question. Young adult with fractured shaft femur or fractured shaft tibia. When do you operate with reaming or without reaming? And any injection hydrocortisone during procedure? What's your protocol? I think we should talk about this in little detail, but because there is no evidence nowadays to wait for the fracture unless the clinical condition is good, and even if the D-dimer test is positive, the anesthetists say that well-hydrated patient can be taken. So it's if you can elaborate it more on this condition, that will be useful for all the people who are listening to you.
Okay, so again, it's back to what we talked about. It's the patient's resuscitation status that is the important thing. Okay. Yeah. So if he's adequately resuscitated, so I would always check lactates and oximetry, etc., in these patients, apart from your clinical findings. Okay, and if that is okay, reaming or not reaming is not the question. Okay, if you're doing a nail, you need to put in an adequately sized nail. Okay, because otherwise you're going to get non-unions, breakage of screws, nails, etc. So you do the amount of reaming necessary to get a adequate size nail in. There's no point putting in a thin nail just because you don't want to ream. There's now enough studies to show that if your patient is adequately resuscitated, if it's even in an open fracture today for the tibia, they've shown that really reaming does not cause any significant problem. As long as you do the reaming carefully, you're not kind of overzealous. Reaming is not what you need to be doing. Yeah?
Do you put a rent in the distal fragment when you're reaming? Let's say proximal.
Some people do, but I really don't do that. I mean, but you can if you want to. I don't know if it makes much difference.
Do you advise to use Dextran 40 or similar in IV fluid in long bone fractures preoperatively?
So no, I mean, I think the role of these solutions, colloids, etc., is now under a lot of controversy. I think you don't use these colloids very often anymore. I think there was a time when we used to use things like Emaxil and Dextran and all these things quite a lot. Now it's usually crystalloids, and that too not huge amounts of crystalloids. And then you would go to blood and blood products. So if it's a massive hemorrhage, now you have what they call the massive hemorrhage protocols, where you use a combination of packed cells, FFP, and so platelets, all in sort of particular ratios to resuscitate these patients. I think colloids like Dextran, etc., are now not used as a regular resuscitative measure.
Okay. The next question is, if open meniscus repair is done in cases with proximal tibial fractures, what is the ideal suture material and ideal suture material size number?
So we are using number 2 Ethibond.
Yes.
Okay, you can use fiber wire and various things, but I think this seems to work well because these are peripheral tears, which is a vascular area of the meniscus. Okay.
Yes.
And so if you get the repair reasonably well, 3 or 4 sutures, they go on to heal.
There is one question from Dr. Somnath Ghatak. In multiple ipsilateral fractures, like fractured femur with fractured tibia, should we go in one sitting or in staged one?
So multiple
fractures, ipsilateral, fractured femur and fractured tibia.
Yeah, so femur and tibia you can do at the same sitting. If again, what is critical is the patient is adequately resuscitated. I think most people still shy away from doing both femurs in the same sitting. Okay, There are people who would do it, but I think by and large, people tend to be a little wary of doing both femurs in the same sitting because there is some risk that you may overdo things in terms of increasing the risk of ARDS, etc.
Yes. Okay, there are few more questions, but they are all already answered. I think there is no point in repeating the same question just because they have sent it. I scanned all the questions.
Good.
All have been taken. If there is anything Ashok wants to say.
Yeah.
Ashok, yeah. You can switch on your video.
And he's mute actually. Ashok, are you there?
I'm here, sir.
Yes.
Okay.
Yeah.
So
We are through, Ashok. We are whatever the major questions have come, we have answered, and there are some repetition of similar questions. So there is no point. Yes. Yes.
So I think I don't have any more questions here now.
Okay.
So
Okay.
great.
Let's wrap it up, sir. Over to you, sir.
I think so, yeah.
Okay. Thank you very much, John. For this was a wonderful experience to see your vast experience on managing all malunions and also your philosophy on preventing complications by treating the patient properly. We are really enjoyed seeing your presentation, and also we are definitely richer by the vast experience you have in this subject. Thank you very much. I thank Ashok Sham. Yeah, I thank Dr. Ashok Sham also for the platform he has created for all of us to learn from one another.
Thank you very much.
Thank you very much, Shiva. Thank you for this kind of invitation and the privilege, and Ashok for organizing these things in such a brilliant manner. It's hard to kind of comprehend. I think 5 years ago, nobody would have thought something like this is possible. But it's been a pleasure. I hope people have learned something. If you get some good feedback, do you work on feedback for these webinars?
Yes, sir.
So it'll be nice to know how I hope people found it useful, and that is the main aim of these webinars anyway. So great. I think I certainly enjoyed it. My voice is cracking now, but otherwise it was really a good experience. Yeah. Thanks. Thank you very much, Shiva.
Thank you. Thank you, sir.
Feedback form is on the homepage of Ortho TV. People can click and give. It's a Google form. Just click and fill it up.
Okay, great. Thanks. Okay, so should we call it a day?
Yeah, once he's disconnecting. Once he disconnects, we can chit chat for a few minutes.